Every opioid we've covered so far gets measured in minutes or hours. Today's drug gets measured in days. Methadone breaks almost every rule we've established in this series. It lasts long. It works through two completely different mechanisms at once. And dosing it wrong doesn't cause a problem right away. It can cause a problem 3 or 4 days later, after you've already stopped worrying about it. What kind of molecule this is? Methadone belongs to a chemical family called the diphenylheptanes. Structurally, it doesn't look much like morphine or fentanyl at all. It's a fully synthetic opioid, and it comes in oral tablets, oral solution, and IV formulation, with genuinely excellent oral bioavailability, which already sets it apart from most of the opioids we've discussed. 2 mechanisms, not one. Here's what makes methadone pharmacologically unusual. It's a potent mu receptor agonist, same as every opioid in this series. But layered on top of that, it's also an NMDA receptor antagonist, 2 completely separate mechanisms working simultaneously from the exact same molecule. The mu activity gives you everything you'd expect: analgesia, sedation, respiratory depression, pupil constriction, and a milder degree of euphoria than you'd see with morphine. The NMDA antagonism does something different entirely. NMDA receptors play a central role in central sensitization, the process by which the nervous system becomes progressively more sensitive to pain signals over time, and by which tolerance to opioids tends to develop. By blocking NMDA alongside activating mu, methadone appears to partially resist the tolerance buildup that limits other opioids, and shows particular promise for neuropathic pain, the kind of nerve-based pain that classic opioids often handle poorly. This dual mechanism is the single fact that separates methadone from every other drug in this lecture series: absorption and digestion. Oral absorption is genuinely excellent. Methadone gets taken up rapidly from the GI tract, which is exactly why it works so well as an oral medication, unlike morphine with its heavy first-pass loss. It distributes into a large volume, extensive tissue binding throughout the body. What the liver does to it. Hepatic metabolism handles methadone, converting it into inactive substances that clear out through urine and bile, with only a small fraction leaving unchanged. Nothing especially unusual there. What's unusual is what happens next. The half-life that changes everything. Methadone's elimination half-life runs 8 to 59 hours, with a mean right around 26 to 35 hours. Sit with that range for a second. One patient might clear this drug in under half a day. Another might take nearly 2.5 days to clear the same dose. That's a staggering amount of interpatient variability, and it's baked into this drug's fundamental identity. Here's the piece that actually matters clinically. Analgesic duration and elimination half-life are not the same thing. A single dose of methadone might only control pain for a matter of hours, even though the drug itself is still sitting in the body, being cleared slowly for days afterward. Give a 20 milligram IV dose, and you'll get postoperative analgesia lasting more than 12 to 24 hours, directly reflecting that prolonged elimination. But if you're dosing methadone repeatedly, more than once daily, which is common in chronic pain management, the drug can quietly accumulate in the body, building toward high plasma concentrations well after you think you've reached a stable dose. The danger this creates. This is where methadone becomes genuinely different from every drug we've covered, and genuinely dangerous if you don't respect the pharmacokinetics. Because the drug accumulates slowly over days, respiratory depression from methadone doesn't necessarily show up right after you increase the dose. It can show up several days later, once accumulated plasma levels finally climb high enough to matter. A patient can look completely fine on day 1, day 2, even day 3 after a dose increase, and then develop significant respiratory depression on day 4 or 5, seemingly out of nowhere, purely because the drug finally caught up with them. This is precisely why dose adjustments should never happen more frequently than every 5 to 7 days. Start low, go slow, and then wait, genuinely wait, before you adjust again. Compared to morphine for withdrawal. Methadone substitutes for morphine at roughly 1/4 the dose. When it's used to taper a patient off opioids in a controlled way, managing withdrawal in someone physically dependent, such as a patient with heroin dependence, the withdrawal produced by tapering methadone tends to be milder and less acute than withdrawal from morphine. That prompt onset, efficient oral absorption, and long duration are exactly why methadone became the classic agent for suppressing withdrawal symptoms in physically dependent patients. Clinical uses. Chronic pain. This is methadone's primary modern role. Neuropathic pain specifically, where the NMDA antagonism gives it an edge over pure mu agonists. Cancer pain. Opioid-use disorder, maintenance and withdrawal management. Opioid withdrawal therapy more broadly, and long-lasting postoperative analgesia. A single well-timed dose can cover a patient for well over 24 hours. Why methadone over slow-release alternatives, and why not? Methadone has been proposed as an alternative to slow-release opioid formulations for chronic pain, partly because of its relatively low abuse potential, and the NMDA antagonism may genuinely help with neuropathic pain, while limiting how much tolerance develops over time. But there's a real downside to weigh against those advantages. The principal disadvantage is exactly what we've already covered, that prolonged, unpredictable half-life. When methadone is given more than once daily, as chronic pain regimens often require, the drug can accumulate to high plasma concentrations and produce significant ventilatory depression, sometimes well after the regimen seemed stable. For this reason, slow-release formulations like oxycodone may actually be preferable to methadone, specifically for outpatient postoperative pain, where you don't have the same close, extended monitoring you'd have for a chronic pain patient established on a long-term methadone regimen. Side effects. The core side effect profile resembles morphine closely: respiratory depression, constipation, biliary tract spasm. But there are meaningful differences worth noting. Sedation and euphoria are less pronounced with methadone than with morphine. Miosis is also less prominent, and interestingly, complete tolerance can actually develop to this particular effect over time, something that's less consistently true for morphine. Common findings overall: respiratory depression, sedation, nausea, constipation, and that comparatively milder miosis. The cardiac warning that demands attention. This is the other piece of methadone pharmacology that genuinely sets it apart, and it's exam critical. Methadone prolongs the QT interval in a dose-dependent way. That prolongation carries a real risk of torsades de pointe, a potentially fatal ventricular arrhythmia. This isn't a theoretical footnote, it's a defining safety concern for this drug, and it's why patients on methadone, particularly at higher doses or with other risk factors, need baseline and periodic ECG monitoring to track the QT interval. Combine QT prolongation risk with the delayed accumulation-driven respiratory depression we already discussed, and you have two separate mechanisms by which methadone can quietly turn dangerous well after the dose was actually given. Respiratory and cardiovascular effects, the full picture. Respiratory depression follows the standard opioid pattern, but remember, with methadone, that depression can be genuinely delayed, and the risk climbs specifically with accumulation from repeated dosing. Cardiovascularly, hemodynamics are generally stable, and histamine release is minimal. But QT prolongation remains dose-dependent, and the associated torsades risk is a defining feature of this drug's safety profile. Comparing it to the other opioids. Methadone. Excellent oral bioavailability, analgesic duration over 24 hours, half-life 26 to 35 hours, genuine NMDA antagonism, and a major concern profile built around QT prolongation and delayed overdose. Morphine, moderate oral bioavailability, duration 3 to 4 hours, half-life 3 to 4 hours, no NMDA activity, concerns centered on histamine release and constipation. Fentanyl, poor oral bioavailability, duration 30 to 60 minutes, half-life 3 to 7 hours, No NMDA activity, primary concern being chest wall rigidity. Remifentanil, essentially no meaningful oral bioavailability, duration 5 to 10 minutes, half-life around 0.1 hours. No NMDA activity, primary concern being hyperalgesia. Look at that lineup, and methadone is the clear outlier, the only one with genuine NMDA activity, by far the longest and most variable half-life, and the only one carrying a serious cardiac arrhythmia risk as a defining concern. The high-yield summary. Methadone combines mu receptor agonism with NMDA receptor antagonism, a dual mechanism unique among the opioids in routine clinical use. Oral bioavailability is excellent, with rapid GI absorption. Mean elimination half-life sits around 26 to 35 hours, with a genuinely wide range from 8 to 59 hours. Analgesic duration is nowhere near as long as the elimination half-life. That mismatch is exactly what makes accumulation so dangerous. Dose adjustments should happen no more often than every 5 to 7 days. Repeated dosing carries a real risk of accumulation, and delayed respiratory depression can appear days after a dose change that initially seemed fine. QT prolongation and torsades de pointes are classic, serious concerns tied specifically to this drug. The NMDA antagonism may reduce opioid tolerance and offers particular benefit for neuropathic pain. Miosis and euphoria are less prominent than with morphine. Use extra caution in liver disease, given reduced clearance. And for straightforward outpatient postoperative pain, slow-release opioids like oxycodone may genuinely be the safer, more predictable choice. Pulling it all together. Methadone. An opioid that works through 2 mechanisms instead of 1, lasts for days instead of hours, and hides its danger behind a delay most other opioids simply don't have. Respect the half-life, respect the QT interval, and never mistake a quiet week for a safe one. With this particular drug, trouble arrives late. I'm Anesthesia Buddy. Stay sharp, see you in the next one.